Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to all the to all the HPUPN staff inside and outside. So today I'm Dr. Azifah and Associate Prof. Shubu Hao. With me, we will appraise on a very interesting paper which is estimating excess mortality due to the COVID-19 pandemic in Malaysia between January 2020 and September 2021. And without further ado, I would like to invite Prof. Shu for his welcoming speech first.
Okay, so we are appraising a paper that is very, very interesting because it was actually produced by our own colleague in UM. And we always read about COVID-19 research and papers from other countries. But this paper actually is trying to compare uh, how were the mortality rates before the pandemic and during that period of I think about 21 months during the pandemic. So we would then be able to see or assess whether the way they uh, uh, analyze the data, whether you can follow, agree, and then whether it makes sense and what actually happened in terms of mortality rates before and during the pandemics. So this paper is interesting in that sense, and I think if we are kind of also having the capacity or access to those data, they are all there. If you got the data and capacity to do something similar, and we can actually produce something similar, and you can see that it can be very, very meaningful knowing the results of of the existing data and how they can inform us of what is actually happening in the country when there's a transitions of so-called times. So here is a before and during pandemic. Okay, so MJH is an online kind of journal club. We are promoting kind of open sharing of knowledge and also open sharing of uh, experience and expertise. If you are actually good in certain aspect of uh, research or evidence-based appraisal or something related to the topics of the paper, this is a platform that we want to share our knowledge and expertise. Okay, so feel free to ask anything or feel free to comment or even feel free to share your knowledge. Okay, so we have Dr. Azifra from CIU, who is actually have a very keen interest on statistics, and is going for a master science degree in medical statistics soon. And this paper, I would hope that she would, a kind of launching pad for her to go into her study. Okay, Azifa.
Okay, thank you, Prof. Chu. Actually, this paper is very interesting. A kind of different kind of paper that if some of you notice that our MGH series rarely discuss on the statistical part. So this paper is kind of eye-opening actually, but I think if there are any new vocabulary from the statistical part that you heard, actually don't worry. It's also same with me. So we're gonna learn together today. So let's begin our journey. So as an introduction, COVID-19 was declared as a pandemic by the WHO in March 2020. With over 286 million confirmed cases and more than 5 million deaths worldwide. And however, these figures are likely to be underestimated to the true burden of the pandemic, maybe due to lack of testing, due to that MCO. And in Malaysia, we are upper middle income country. Implement the public health measure like the MCO, able to contained of COVID-19. And the country experienced outbreak was driven by the cluster in the factory, prison and immigration detention center. And also the emergence of the more transmittable variants, particularly the Delta variant, led to a damaging wave in the mid 2021 until September 2021. And in Malaysia, we record more than 2 million cases and more than 30,000 deaths by December 2021. So, as we know that in Malaysia, we are heavily tax-funded public health system in Malaysia, and they are play a major role in the vaccinating, screening, and treating the population. And I think this is one of the issue because the tax-funded public health, and we use a lot of money on that, and it um sometimes cause a issue of collapsing the system actually. And then historically, and all cause mortality actually has been used for the surveillance of infectious disease. So currently, we try to use the all cause mortality to detect the excess mortality. And then we hope that excess mortality can capture the unreported COVID-19 death and the collateral damage from the overwhelmed health system as well. And then the objective of this paper is basically to investigate the possibility of excess all-cause mortality in Malaysia due to the COVID-19 pandemic and its age, location, and the cause-specific distribution across Malaysia. So it goes straight to the method. Okay, so the method is basically they divide it into the data and also the statistic. So first of all, we're gonna see how the data being taken actually, how they get the data. So in Malaysia, all death in the country need to be reported within 7 days for the Peninsula and Sarawak. And while for Sabah, they allow it up to 10 days. And then the mortality data will be compiled into the National Mortality database, which is maintained by the DOSM. And then the DOSM will counter check by liaising with the MOH and the police department on the completeness of the registration. However, during the early phase of COVID-19, there are disruption in the service provided by the DOSM. So they might be delay reporting up to 3 months of the mortality before DOSM able to release it. So basically, as I mentioned before, the data is obtained from the DOSM from epidemiological week 1 in January 2016 to epidemiological week 39 in the September 2021, accounting up to 69 months of the data. And then the additional data would retrieve from the official MOH COVID-19 data repository between 1 January 2020 to the 30 September 2021. And then what is the variable that they are taken? What is the data that being extracted? So they took the age of that, sex, nationality, ethnicity, place of residence by state, and also the cause of death or COD lah. And then how they code the COD. So for most of the clinician know that we are using the ICD-10 for our death certificate, and we need to key in that the coding of ICD-10 in the system to ensure that in the next year we're going to get the funding based on the accumulation of the disease, based on the burden of the disease. However, unfortunately, some of the code is not being written, and they gone by the doctor, and they gonna use a less formal code which will be certified by the police personnel. And unfortunately, ICD-10 codes was unavailable from 2019 to 2020 during the data extraction.
Do you know the reason why during these 2 years there were no coding?
I'm not so sure, Prof, because it did not mention in the paper basically, and I tried to find from the apa?
Those
Yeah, but I cannot find it. Why?
very strange, huh?
Yeah. Tu lah. And Prof, do you use the ICD-10 and HSAAS?
It's actually uh
It should, right?
I think the during the development of the electronic health record, ICD was the coding language,
Mm-hmm.
and primary care actually suggested another coding classification. But I'm not so sure about now the new electronic health records. But it's actually widely used in many health record. It's actually kind of automated coding. Once you choose a diagnosis, so the ICD code will comes out. It's actually incorporated into many health record system.
Mm-hmm. In Asians, they already use the ICD-10. Is it? Because I still remember, I think, or for the past 2 years, I did not code using the ICD-10 during discharging of the patient.
I'm not very clear about the current system because it's always like it being updated. If I say no, but I'm not sure they
Mm-mm.
applied it fully or not. But it was there in the earlier health record system.
Yeah.
But now I think nowadays we rarely click the diagnosis menu. We just type in the diagnosis. So I wasn't very sure whether the new health record system has incorporated or not the ICD-10.
Yeah, because I think if we incorporate ICD-10 actually for the database management and also to do a research, it's much
Should be
easier actually. Huh?
should be
Yeah. Um,
I'll check with them.
yeah. And then for the codes actually that from the traffic road accident also identified using the ICD code. And then that due to RTA for the year 2029 to 2021 because the ICD code 10 was not available, they use text mining free of COD such as use the keywords such as motor, traffic, road, crash as well as the other Malay equivalent term. So I'm not I think from this method, I'm not sure how many actually they might be some leftover because they might not able to get all the death from the traffic road accident actually. And then for the COVID-19 mortality in Malaysia, actually they divide it into two, into a COVID-19, death due to COVID-19 or death with COVID-19 with a predefined set criteria by the MOH. So this one, sorry, I did not find it, all the predefined set criteria on the MOH. However, only death due to COVID-19 are accounted as a COVID-19 mortality. So next, we go straight to the statistical analysis. So actually, there are many steps in when they are doing a statistical analysis, and I am quite impressed with their statistical technique. First of all, when we are doing after we doing a data cleaning, we need to check the missing data and also outlier. So they mentioned that for the missing data management, they use random imputations for the data with no day, but with a month and year, which is account for 2% of data in 2017 to 2019. And then after they do the random imputation, the data then being used to categorize the mortality into the epidemiological weight. However, unfortunately, I did not know what kind of random imputation that was done. And then they did not mention of what kind of missing data for the data, whether it is MNAR or MCAR. And I look forward for actually if they have a further explanation on how they manage the missing data. And then after they settle the missing data, they will explore the temporal structure of the data using the lowest STL on the time series. So lowest STL is basically kind of advanced statistic where they combine polynomial model with a weighting into to decompose the time series. Decomposition means that it will make it simpler. They will reduce the complexity of the time series by using the lowest. So and then after they did the decompositions, they able to eliminate the factors of the seasonal. Then they will do a surveillance of the potential aberrations within all cause mortality counts by using a flexible Farrington algorithm. So flexible Farrington algorithm actually started from 1992 by a statistician, which basically they use it for the surveillance to look for the outbreak. So here we use it slightly different where we use it in term of to find the excess mortality using the similar algorithm. And this algorithm actually, even for the mortality, has been used in the all over the world, in the Japan, and in Malaysia. We just no, in the East Asia actually, we just recently start to use it. And then what the algorithm do is basically it will be formulate to predict an observed number of count using a set of reference value from a window of size W up to the B years back. But actually it's there are a lot of steps in the algorithm which we are not discuss it now lah. And then after they already have the reference value from the algorithm, from the parenting algorithm, they will fit it into the statistical model, which is they use a over dispersion Poisson generalized model with one-sided confidence interval. So here, they use a Poisson regression. So Poisson regression actually are regressions that use for the data with the count data. So you want to find the relationship from your independent variables and your outcome is the count data. However, Poisson regression has an issue with over dispersion, has issue with the dispersion. Dispersion means issue is the variance. So when there's an issue with the variance, which is the issue is basically for linear regressions, when they generalize it, it will able to relax it, and they did not to have one of the assumption that the data need to be equal variance. So over dispersion Poisson generalized model able is a very good choice for this kind of that of the kind data. And another thing is it use a one-sided confidence interval. So when they use a one-sided mean confidence interval, it means that it already has a direction. Because the aim of the study is to see if there is an any access model, they're gonna use on the direction of the right side, which is the higher side. So they want to see if there is any um access mortality rate. And here they use a lot of reference to decide what kind of window that they're gonna use. So they decide a window of 3. And sorry, the B is 5 will be utilized, and then the data, and then after they use the Poisson generalized regression model, and then the data will further divide into the 10 periods during the implementation, and then they're gonna fit it into the model. And then before they did it, they already used the data from 2016 to 2019 for the model training.
As if I can I like make it ask you try to see this analysis strategy, right?
Mm-hmm.
How do you see the whole analytical strategy here as to the study objective? Why is it this is considered as good or fair?
Um, I think this is very good, Prof. Actually, I'm quite impressed with the way they plan it. It just I think if they have it will be better if they have their own statistical plan that we can see and we can actually replicate it.
Can you comment by relating it to the study objective?
Because the study objectives is basically to investigate the possibility of the excess all cause mortality in Malaysia. So in order um in order to do that, first we need to understand what is the excess all cause mortality. Means that excess all cause mortality means that all the mortality in Malaysia. So they wanted to see if excess all case in Malaysia is being increased, um, which usually you need to have the observed and also the predicted value. So if the observed value is higher compared to the predicted value, they will get they will get the excess mortality. So here, after they fitted the time series into the over dispersion Poisson regression, they will get the predicted and also the observed value, which I think it will answer the objective of the study actually. Or you have another thing that's in your mind actually, Prof?
No, to make the all of us here know better understand, like say explore temporal structure of the data. Would you be able to explain a bit why is this necessary? The second one.
Oh, the explore temporal
Yeah.
structure of the data. Um, because in a time series, it's basically a very complex thing. So when they mention they want to explore temporal structure of the data, what I do understand is they want to see the pattern of the data. The
Across the year, is it from
yeah, ni
2016 to 2021? Is that so?
yes, correct, correct. But actually, when they analyze it from 2020, because the 2016 to 2019, they use it for model training, and they analyze it after that. Actually, the ones that they presented in the result.
Okay.
Yeah. So when they see a temporal structure of the data, because they did a time series is basically a very complex. So they want to reduce the complexity by using lowest. So in a time series, what we are interesting is basically they will divide it usually on the three things lah: aberrations, the trend, and also the season. So the lowest will help in term of smoothing the line. Which because when they're smoothing the line, actually there's an algorithm lah. They will use a multiplication and additional punya rule where they will after they after they have to break it into the three model of the time series for the aberration trend and also the season. They will eliminate the effect of the season and also trend into a one time series because they want to see from the final time series if there is any aberration issue.
What do you understand by aberrations?
Aberration means any spike of the case that is irregular from the trend actually or the seasonal effect.
The predicted, is it?
Yes.
From the predicted, is it?
From the I can't say so as well.
Okay. How about is it always necessary to because the paper also described they did sensitivity analysis
Yes, correct,
with
Prof. I am not reached that part yet.
yeah, with different okay, with different week and also years. Okay, I think you may proceed and then we may understand further. Okay.
Yeah. Okay. After they fitted the models in the Poisson generalized regressions, so they will further stratify it into the age group, on the gender, COD, ethnicity, and also the nationality. And they did not only stop at that; they do a sensitivity analysis by varying the week and also the years to 2 to the 8 weeks, and also the B is for the years 2 to 5 years. And then they also compare the Farrington algorithm with Poisson regressions with the Bayesian hierarchical approach modeling. So and then they will report how they report the excess mortality is basically they report it as the difference and percentage change between the observed mortality, the predicted point estimate and its 95% confidence intervals. And then the excess mortality attributed to COVID-19 will be calculated by taking the proportion of COVID-19 mortality from the excess mortality. They use R with the surveillance anti-diverse package version 3.6. So I think this from this slide, I think the thing that very interesting to me is basically on the sensitivity analysis lah. So when they are varying the window period and also to see the effect whether by varying the window period whether they will have the similar outcome, and also they compare it with the latest approach of assessing the excess mortality on the Bayesian hierarchical approach modeling. So for those who kind of new on the um, Bayesian actually is kind of different approach compared to the frequencies But however, the model and the frequencies usually can be incorporated in the Bayesians. So Bayesian use prior knowledge. Means that we use to gather the data on the data that we know from the previous research and the expert opinion, and also they will combine it with the likelihood. Likelihood is basically a data, and they use into a posterior modeling that they do a posterior distribution, and from the posterior distribution, and from the posterior distribution, they will do the inferential analysis after that. So here, they choose a Bayesian hierarchical approach model. However, they did not explain further how they do the Bayesian hierarchical approach modeling in this paper.
Did they comment that the sensitivity analysis were actually generated similar results or different results?
Uh, in the result section on the supplement, yes, they have it.
I mean, they compare with the Bayesian hierarchical approach modeling
Uh huh.
compared to that Farrington algorithm.
Uh
Did
huh.
they say anything about this sensitivity analysis? Was it similar to Farrington, or was it any observed differences?
Do you mean the outcome from the Farrington?
Results. Yeah.
Yeah. They mention it in the result. Actually,
I mean,
it has.
they presented the Farrington algorithm,
Uh
and
huh.
then they compared that with this sensitivity analysis. Did they comment anywhere that the two analytical strategy actually uh, produce similar results or not?
Yes,
They did mention, huh?
they did mention in the paper. And actually, there is a table in the supplement where they compare the result from the Farrington and also the Bayesian. But they use INLA they use INLA for Bayesian hierarchical approach modeling.
Okay.
Mm.
So if I
If
understand, is there any more slide on statistical analysis?
no.
No, right? So if I understand it, so it's like this, you know. So now they kind of wanted to check whether the pandemic causes more mortality in Malaysia. So they go to the DOSM, they extract data all the way back from 2016 all the way to 2019, just before the pandemic year of 2020 to 2021, right?
That's for
So
training, bro.
yeah,
Mm.
they want that before pandemic year 2016 to 2019 is as a kind of a data set for them to predict what would be the predicted mortality during pandemic year, because during pandemic year we don't have the actual numbers of death, because pandemic occur like all over the land, isn't it?
Mm-hmm.
So they based on that numbers of years of mortality rate, assuming if pandemic never occur, this would be the so-called mortality rates lah during the pandemic year. So they have to have that, you know, in
Mm-hmm.
order to have that properly established. So they apply all that algorithm lah. Yeah. So you need to uh, agree that this is the way to predict the mortality rates. We know that that cannot happen in real life because pandemic occur. However, statistically speaking, they can actually kind of try to predict if in the absence of pandemic, this would be the mortality rates by basing on the previous years. So if you understand this, then you can argue why taken from 2016 all the way from 2016 to 2019. So that is 4 years, isn't it?
Mm-hmm.
16, 17, 18, 19. So almost 4 years. Is it something standard of statistical practice in predicting, or should we use more years, or can we use lesser year? I'm not so sure whether Azifa you can comment on this later. So once
Mm-hmm.
you agree with this, so they have a predicted kind of a mortality rates should pandemic never occur. Okay, so you must actually then agree with that. Then they have the data, actual data of observed mortality during the pandemic year, the 2020 to September 2021. So now you have the predicted mortality should pandemic never occur. and then you have the observed mortality. So now they want to see excess mortality. But you have read the paper, you know that in early pandemic 2020, there wasn't any excess mortality. Rather, there's a reduction in mortality,
Mm.
isn't it? So
Yes.
if not sure whether Azifa you can also comment, they kind of applied one tier.
Yeah, I think I commend it because you look at the direction of it, because in our study, in their study basically they want to look at the upper side of the excess mortality. So it's already have a direction. So they choose to have a one tail actually.
The actual result during year 2020, there wasn't any excess actually. They actually reported there's a reduction in mortality. The excess only come in year 2021, like July onward. So I'm not so sure whether that has any impact or on their analysis in year 2020 when there is actually a reduction rather than excess. So then by applying one tail, uh, I think there are pro and con. So I'm in a normal research, I would be able to comment, but in this kind of simulation study, I would not know how would that impact their analysis,
Mm.
because
Yes.
they kind of already like take it as it's going to be mortality excess mortality. But then they actually observe is it was it a reduction because orang semua orang duduk kat rumah kan, because all
Mm.
are
Mm.
lockdown. So a road traffic accident, not people are traveling, so there's no accidents. But then they only noted there's a mortality most likely due to COVID in later year 2021 lah. So there's a kind of I'm not so sure whether why they actually proceeded and reported their one tail kind of um, analysis, but it may not be one tier or this just they report the upper limit. Later, I think
Mm.
maybe we can see the result and then we can discuss again about
Yeah.
that. So this is the statistical strategy that I think the main task here, if I understood it, is to get the predicted mortality in year 2020 and 2021. And this is the most complex and difficult part. If they don't predict it well, whatever that they are going to report on the excess or reduction in mortality will be unreliable. So they are trying to apply the statistical analysis or strategy that is most reliable to predict the mortality rates during the pandemic year. So we have to agree with them on this. So if you agree, then the rest will be meaningful lah. If you don't agree, then you can just throw the paper away. Okay.
So do you agree, Prof?
I think so far okay, but I actually have to read further on the approaches whether that is acceptable. Usually, people use a longer historical data. They just apply 4 years. I may be wrong.
Yeah.
No, they never kind of argue and defend, give reasons of their
Yeah.
choices lah. I
Correct.
suppose they can be
I
better.
think there's a limit for them to write in the paper, but I think they can write further in the supplement.
No, that's not the reason. In order to complete reporting, that's not the reason. Just can give explanation for the choices just in 1 2 sentences extra.
Yeah. Mm.
I don't think that's
But
the
but I think it kind of a lot of other study on the excess mortality they use a one tail as well. Maybe we can discuss it further later, Prof. Yeah.
okay.
So and then we go straight into the result lah.
Yeah,
So this is actually the first table from the study. I think Prof must tak agree dengan P value dia kan. Dia letak P value kat sini.
it is not good. You have to
Uh,
report the actual p-value.
yeah.
I think,
So do
yeah.
you agree they put the P value here, or you're not agree with the P value, or this one is should be just a descriptive sahaja?
I think this is a trend analysis, so they are trying to show whether there's any difference in different period of time. I
So,
think, yeah, because of sample size, you can see everything very significant because of sample size, purely by sample size. You can see the difference is so small,
yeah, yeah.
don't
The
you?
difference is not that much actually.
Yeah, but it's okay. It's not comparing like a control group and intervention group.
Correct, correct. Yeah. But this one is using chi square and also the t test lah.
Just
So
be
when
aware because sample size so huge,
yeah,
p-value anything also be significant. So-called like below 0.05. They use 0.01. I think they use 0.001 also could be actually significant. Because
yeah.
sample size so huge.
Mm-mm. Okay. So any participant want to comment on this? Sure.
Is there
Can
any
you
pattern that you want to highlight?
here actually no, Prof. Do you want to highlight anything here? Because it almost similar from the three different from the three different period actually.
We can see the mortality is actually, but the P3 periods are not the same lah, to compare.
But this one is for 4 years. Yang satu ni. The time frame is not same actually.
Yeah, so
Yeah.
it's hard to
Yeah.
compare.
Yeah. So if you want to compare 4 years and then 1 year and another year, I don't think it's fair lah in term of you want to mention on term of the total mortality.
Their percentage is column percentage, or I think it's column percentage, is it?
Kalau percentage, I rasa almost similar for each lah.
It's a
But
column
if
percentage lah.
yeah, tapi kalau but if in the total number, it might be different, especially on the training period, 2016 to the 2019.
If you column percentages, then is quite okay, quite informative to compare because they have the periods specific denominator.
Yeah,
But you can see all very similar lah.
mm,
Yeah, isn't it?
yeah, correct. Okay.
Except the road traffic accidents lah. Traffic accident memang during the pandemic no one traveling, so it's a 1.9, 1.2. It's like
1%.
less lah.
But 1% less actually is a very big
No,
number.
no, you cannot compare. You must also see this is called absolute risk difference or relative risk difference. This is absolute difference is one time difference, you see.
Mm.
It meaning it's 100% different. Like 1.2 compared to 2.7 is 100, almost 100% different. So it's one time different. Okay.
Yeah. Yeah, lah, because the total number is very high. That's why it's very high. Like actually, even though it's just a 1%
Uh,
difference.
is
But
the different here is absolute difference is 1%, but the relative difference is 100%.
faham. Can we proceed, Prof?
I think there's a comment
Actually, I cannot read it from here. Yeah.
Nurul Husna. I think he also agreed that they have to report the exact p-value. Yeah, and also the chi-square value. Yeah, that's a good statistical practice, isn't it? Okay, Azifa, we can
Okay.
proceed.
Yeah. Okay. Next, this is the second graph actually for the time series where they divide it to the 10 period of implementation. So you can see that all cause mortality actually it is a very small difference between observed mortality and predicted mortality in 2020. However, there is a sharp rise
Mm,
during actually from the June to the October 2029.
yeah.
Yeah, actually and then it will reduce back on the October 2021,
No lah,
which
they
is
stop at that, isn't it? They stop at
yeah.
September. I think they
Yeah, correct.
they shouldn't draw that line. No, they should
Yeah.
stop there. Otherwise, it's misleading. thought like you think it's a drop. It's not a drop.
Yeah.
It stopped
So
there.
like I thought, yeah,
Mm.
because they just stop it here. I think and then here actually during the Delta wave kan.
I don't know.
Yeah,
I
this
think
is
they have another graph showing that. Is it? I'm not so sure.
I think this is
I don't remember.
the graph actually, huh?
Oh, okay.
Yeah,
Do
yeah.
you, can you comment on that yellow kind of band? Is it the 95 upper limit 95 confidence interval? Why is it a band kind of thing? Why not a line?
Yang tu I tak boleh comment bro.
It's a predicted mortality. I think it's the confidence interval. I think,
Yeah, yeah,
but they
it
did not
might.
clearly footnote it as such, isn't it?
Yeah, I think so.
Mm,
It's possible on that, huh? So next is on the observe all cause mortality by state.
that's it.
Yeah. Uh,
Again, they don't actually kind of put a clear legend. I just assume the black line is the observed mortality rate. The yellow band is the predicted one. The
yeah.
red line, is it the red line is the one caused by COVID?
Yeah, I think so, but it did not write it in
They don't
the
put a
yeah.
clear. Oh, I think they do. And you
Is it
see
they
on the
write it?
graph, oh, the graph O is there. So I think the legend shouldn't be there lah. Can you see the graph O for Wilayah Persekutuan Labuan? Is there. Okay,
Wilayah. Oh,
the
yeah.
first time I don't see it also. Is there any interesting
Mm.
pattern here?
Mm,
It's a
almost I think it's almost
it's a spike
similar for all
at
of
the same
yeah.
almost the same time, isn't it?
Yeah, but except for wilayah
Yeah.
Persekutuan Putrajaya, yeah, the amount is very little.
What do you mean by very little?
Means that the amount of mortality is around 0 to 10 only.
Yeah, whether that's true, huh?
Yeah, I think because they're really strict at the wilayah Persekutuan Putrajaya.
Is it? Or
I,
what?
I yeah, because there is a lot of orang besar there.
Mm,
They need to contain that place to be as safe as possible.
I thought in my memory, Putrajaya also was having quite high mortality on certain time. No?
Compared to other state, I rasa tak prof. Because there are a lot of roadblock when you want to go to Putrajaya during that period actually.
But they observe mortality, there's a spike there also lah.
During the June. Yeah.
Almost there's a every state got a spike there, isn't it? Except like Terengganu, kan? Macam not very clear spike there. My model.
Perlis as well.
Yeah, police.
Perlis and Putrajaya.
So the band is very huge, very wide, for certain states.
Yeah.
Meaning their estimation, their prediction wasn't very accurate,
Mm,
Not sure why. Like police is very broad, Putrajaya is very very wide.
yeah. I think because the number is
It's more, is it? Yeah,
yeah, yeah. So the prediction, I think the confidence interval
yeah.
become wider.
True. Okay, so may not be so accurate for those state lah, isn't it?
Yeah, I think the smallest band is for the Kuala Lumpur, wilayah Persekutuan
Mm,
Kuala Lumpur
true.
actually,
Yeah,
and also Selangor. This place is kind of bigger.
yeah. Or interpretation should be cautious by state lah, isn't it? Cannot
Correct, correct.
take
Mm,
take the whole country.
Maybe if they use much more historical data, the prediction
Ah,
would be better. I think
that's why. Yeah.
because I think one of the key factor in the lowest actually they need a very large number.
Mm.
Okay, then on for the age group, so we see basically for the age more than 60, um more than 60 years is the highest number of mortality.
The spike lah, a spike for those 15 and above lah, kan.
Yeah,
Those below that,
more more
yeah.
than yeah. Spike tapi 41 to 59 memang ada spike banyak lah, as well as 15 to 40. 15 to 40, 41 to 55. There's a large spike here, a very exponential raise from the June 2021.
You know why?
I think yang Delta kan, Prof?
Or when you compare to those like below 15, above there, there's no spike.
Ya, semua dekat rumah mah.
School was closed, so all
Mm-mm.
stay at home. So they were not exposed to any risk, and there's no mortality. Or the observed mortality is actually lower than the predicted
Mm.
compared to pre-pandemic kan. So they
Yeah,
will go
correct.
all over the place, and they may
Yeah.
get into problem all that.
Mm.
But compared to those for above 15 years old and above,
Mm-mm.
so this could be the those who are more active socially or working. The more than 61 will be the high risk groups, so they were more likely to die if they were infected. So it actually was socially more active or less active,
Mm-mm.
isn't it?
Mm-mm.
Mm.
But I think if they apa tu, they try to look at another perspective, actually when everybody at home, actually the parents will be depressed as well.
Mm. Yeah lah.
Mm. Okay, next. Okay, I think kita tengok supplement. So next is basically on the supplement. We go because I think from the statistical analysis that they are planning to do, they put it most of it in at the supplement. So if you guys want to see how the composition is being done from the for the trend analysis, actually they will divide it into the seasonal trend and also what you know. But please do not ask me how they do it lah. Actually,
Yeah. How about seasonality? What seasons are there? What kind of seasons they are talking about? Or is it a statistical term?
it is a statistical term actually, Prof.
What is
Uh, yeah, actually they want if I'm not mistaken, is seasonality is basically they want to see the trend. That's why you see the trend here. From the they want to see the trend and also the pattern.
Yeah, I mean
Yeah,
the curves does not look the same. So
yeah,
what does it mean? This one, the mortality count, and then the seasonality. I mean, I believe they do tell us something differently, but
yeah,
I
correct.
don't understand seasonality in the first place. So I don't know why there's a kind of a regular dip, that kind of thing, on the seasonality line graph. The trend, I suppose, is kind of average lah. So you can see the average was actually almost like the same until year 2020, and then there's a rise. Must be due to COVID lah. But the second graph seasonality, I don't know why, how to, I mean, what actually you want to inform
What
us about.
what actually seasonality means at first? Actually, kind of actually we need to understand it first. What is seasonality? What is a trend? What is a what you know? Is actually, yeah. I think that's the first thing that we need to understand in the time series, but also did not able to comprehend it correctly. Actually,
Yeah. So there are much more comment from Nurul Husna. I think Nurul Husna is our colleague, statistical statistician, is it? Husna? Can
is it Husna from the
No,
faculty?
I'm not. Okay, sorry.
Is it no?
So I think it no, because this is journal, this is scientific report. It's not a statistical journal, isn't it?
Yeah, yeah.
Yeah. Okay. Thank you, Husna. You're from nutritional department. So they have to explain.
Oh,
They have to explain. They have to explain what is seasonality. For readers who are not uh, with a statistical background.
oh,
Otherwise, hmm,
I think the mention here is basically the seasonal. No, it's not mentioned in the article, but I just read it. Seasonality is basically they're repeating short-term cycles in this series.
what does that mean?
I think when from the mortality count here, I think they will kind of season spike here, and there is here, and also here. But if it is out of the norm, like here, it's not being as seasonal, but it will goes into the white nose here, the aberrations.
We see the unit, they kind of hovering around zero line, the seasonality.
Seasonality is zero line. Oh, you mean here? Oh, the starting. Oh, yeah, I understand it. Huh? I think next year, Prof, kita buat course lah.
Mm.
Forecasting.
I mean, the paper itself has to explain. And
Yeah, yeah.
it's
But
supplemented.
because I think time series actually I tried to spend some time to read it, but it's not very easy to understand, especially when there is already some rules, multiplication rule, addition rule. There's some kind of algebra, and then I just think
Mm,
that I need to stop it
yeah,
somewhere.
yeah.
Yeah.
Okay.
Unless Prof give me another 1 week lah to
No,
read.
authors have to give some sufficient explanation. Otherwise, you don't present it. You present it to make people to understand,
Yeah,
to
correct.
convey some message. So you want to put it there so that people can understand. Otherwise, people have to read another statistical book, is it, to
Yeah.
understand the graph?
Yes. Yeah.
Okay.
Okay. Next is on the observe and predicted COVID-19 associated mortality from January 2020 to the 2029. So here there's the age group and also the state as well as the gender. They interpret it if positive value. If there is a positive value, means that there is a excess mortality, and if this negative value, it is interpreted as reductions in the observed mortality. So you can see here, this line is the observed mortality, and then there is a predicted mortality with a 95% confident intervals upper limit. Only one tail actually. So you see from the predicted mortality is higher compared to the observed mortality. So it will have a negative percentage change, and then excess that will be negative.
Um,
Alright, from nak add on ke?
no, I just not sure how. I'm trying to understand the excess count there. Let's say you go to WP Putrajaya, right? Excess count there, there's a minus 336 and a
WP.
38 plus 338. How did they get this minus 336? Is it 746 minus something? Or 410 minus 746? Let me try and see.
Uh, 38
Oh
tambah
yeah, okay.
38 tambah 372 dapat 410 kan, Prof?
Yeah.
Uh,
So they use 410
uh,
minus
30.
372 to get the
Hmm.
38.
Yeah.
And then 410 minus the upper,
746. It
you get
gets
minus
negative
336.
336. Yeah.
So what does that mean? The excess count, if they minus the 746, what does that mean? They minus 372, I know lah, that's excess lah. Observe and the predicted, isn't it? If they minus the 746 and they get the minus 336, what does that mean?
I think this one is because it based on the confident interval. So it's a very large confident interval means that it's become very less
It's
precise.
not confident interval. Excess
Confi-
count there.
Prof, jadi dia based on 95% confident interval, upper limit dengan upper limit.
Yeah, I mean, I know that. They
Yeah.
use observed mortality
Mm-hmm.
and they minus 95% confident interval upper limit of 746. And
Mm-hmm.
then they get the minus 336. What does that minus 336 mean? Is it reduction?
Yeah, reduction. Reduction.
So this is predicted reduction, not the true reduction.
Yeah, predicted reductions.
Because the excess count of 38 is also predicted also lah,
Yeah.
isn't it?
Yeah.
Okay.
Tapi it's very large kan, the difference. For
Uh,
wilayah persekutuan.
why they use the upper limit 95% confidence? Why can't they use a lower limit?
Because I think they're only interested to look for the excess,
But
not reduction. Yeah.
is that fair? Is that fair?
Mm,
They must give reason. That's why I read
yeah.
it I couldn't follow, and
Yeah, yeah. Faham. I
although
think.
I mean, if you publish in a statistical journal, then I'll be prepared lah. Kena baca statistic all that. But then if you publish in a general journal, scientific report is a general journal.
Mm-mm, mm-mm,
I would expect some more explanation so that at least we don't need to have too much statistic training in order to understand. But that's the way calculation was done lah. At
mm-mm,
least I understand. But I don't understand why lah.
mm-mm.
If you go down the columns,
So, do you think it's meaningful?
you see, you must believe and agree with the predicted mortalities. If you don't agree with that, the rest will not be meaningful. No?
Mm,
Let's say, assume agree with the predicted mortalities and agree with their use of 95% confident interval upper limit of predicted mortality. So you get the excess count there, and then you get the percentage change there, and then you go all the way. COVID-19 mortalities were actual observed death as reported, and then the excess death attributable to COVID-19. I think they use a denominator there,
mm-hmm.
like 21. You see, I try to get understand this.
Yeah.
Excess death attributable to COVID-19. How do they get minus 6.2? And how do they get 55.3? I think 59.3 I can understand is 21 over 38, I think.
Mm,
Okay, so 21 over 38, we get 55.3. So you see, all the rest you rest on the excess count there. The COVID-19
mm,
mortalities were actual death reported to KKM. So when you have excess counts of 38, the excess death attributed to COVID-19 will be 21 over 38
mm,
lah.
Faham,
So
faham.
it's not more than 38 lah. So meaning
Mm-mm.
to say, during this whole period, can you show the title of the table again? I think
Sorry? Yang mana Farona?
the title of that
Oh,
table
the title. Okay.
is from when? Or from January to 2020
September. Yeah.
September.
Mm,
So during this whole period, there's no excess of death due to COVID-19, I mean, not, what to say, there are 55.3 uh, percent proportion of death were actually attributable to COVID-19. 55.3 lah proportion in terms of proportions.
mm-hmm, mm-hmm.
But then they have this minus 6.2. Uh, so I don't really then get this one, the minus 6.2. How do you get that? Is it minus 82 divided by minus 336?
Mm,
It's not, no.
mm-mm.
So I don't really get the first half of the number.
Yeah, I think they if they elaborate further,
But
maybe
I
it's
think
easier for us to
we
calculate
just
it
understand.
actually.
Huh?
Yeah.
Sorry, there's someone say Sawana was saying something. 21 divided by 336. Okay. Okay. So that makes sense, is it? Okay. 21 divided by 336. So everything will be the denominator will be they get the denominator for excess count. So you must agree with the excess count. Then only you will get to the excess death attributable to COVID-19. Because the excess death attributable to COVID-19, the denominator come from the excess counts.
Proportions of
Mm.
Excess mortality attributed to COVID-19 calculated by taking the proportion of COVID-19 mortality from the excess mortality. Yeah.
Excess all that, yeah.
Yeah, I think from their reporting actually calculate it. Yeah.
But what does a minus 6.2 mean? Is it, I'm not so sure. This minus 6 point, if it's 0.3, then the proportion of death attributable to COVID-19 were like half more lah. Minus 6.2 leh. So um so it's kind of different, kind of a unrealistic statistic. I'm not sure whether it's meaningful to report in the first place. Maybe I don't quite understand that. Is it meaningful to know to report excess death with the two numbers there? It's one number there and one number there, isn't it? Okay, I think at least we know how that numbers derive, but the meaningful of it, let's see what the author say lah. See what they say.
Okay. So uh and then they did a table for a 3 monthly period from January 2020 to 2021.
Mm.
So from every 3 months there is a table for that, and basically it's almost similar for each month except from the end of the 2021
So they
July.
would actually no observe excess death due to COVID-19 until July, September
Yeah,
2021, isn't it?
yeah, yeah, correct. So here you can see from for the July to September 2021, from the observed and predicted mortality, there is kind of difference. And then the assessed also there's a positive integer here. Here and also for the age more than 60, above 15 lah.
What does excess death attributable to COVID-19 more than 100? That 100 proportion, I mean, I thought the maximum can only be 100%, meaning all death were due to COVID-19. But when the proportion is more than 100, what does it mean?
Means that more than 100 times.
No, excess count, because this excess death were proportion, isn't it? So they have the numerator and the denominator. But when they got more than 100, meaning the numerator is more than the denominator. And meaning to say, so you want to query the predicted mortality here, because observed mortality is true, COVID-19 mortality is true. Let's say take an example, take a smaller number. Let's take the
15 to 40.
15 to 40. You can see that COVID-19 mortality is
Then,
2767,
and
and the
then
observed mortality were 5622. Kan?
5622.
But then they have to account for, even were there no pandemic, there will be still some people who die, isn't it? So the predicted mortality was 3288. If there's no pandemic, so still this 3288 people would die for some reason. And now because of pandemic, so they want to see whether the any additional death, like excess death. So they kind of predicted, based on the predicted mortality, should there be no COVID, it will be 2,334, 2334. However, the real observed mortality was 2767. So then they, you know, uh, produce a more than 100% kind of excess death. It's just that whether that makes sense or not lah. If you add 2767 to, meaning to say, if you add 2767 to 3288, is more than 5622. So something is wrong somewhere. I mean from our logical thinking lah, not from statistical estimation. So something wrong with the predicted mortality lah, I suppose. When you say there's excess death more than 100%, so meaning to say, uh, does that mean there are actually more death not reported? People die somewhere and it's not reported and not known. Macam apa tau? Macam Nazi buried someone in the garden, that kind of thing. Where they are, that kind of thing. Cannot be right. All death in the countries reported and registered. So when you say it's death more than 100%, meaning to say there are somebody missing, there are missing individuals, don't know where. Am I right? Okay, I think so. Zipa, you want to comment or want to go on?
I just want to go on, Prof.
Yeah. All numbers should have a meaning, you see. You cannot
Yeah,
be ignoring them and then just assume people understand.
correct, correct. Yeah. And then this one is on the sensitivity analysis between the RTA, traffic road accident, and also the non-RTA. So you can see here the observed mortality for the RTA compared to non-RTA is actually, I think, basically bawah ni dah sama kan actually.
There's a there will drop in RTA
It's,
lah.
at the end actually.
All drop lah because no one, not many people are traveling.
I think on initial kan, on initial tu drop, and then tapi non RTA actually basically increasing.
Yeah, no idea. Could be include
Yeah,
COVID-19. No?
yeah. Um, and then yang ini ethnicity, and then last one. Then kita pick up last je lah. Dah pukul 11:30. I think this is the last one. For the comparison between a parental approach to the Bayesian hierarchical approach actually. So actually they I think basically it's kind of almost similar for both model.
I thought they are very different.
First different tapi conclusion dia sama je Prof.
Big different lah, like for cumulative.
Kau tengok sini.
The first rows
Oh here. Understand.
also the July to September and April to June as well. Kan? The proportion between the two
In terms of access
are
count.
different. Access count also. And I'm not sure whether they commented and described and discussed about these differences. The sensitivity analysis is actually you want to check whether the robustness of one statistical strategy holds or not when you analyze it differently. But the different analytical strategy must be also acceptable lah. Then if the two agree, then you have very good, credible analysis lah. If the two that you try to compare don't agree, then you have the duty to explain why they are different. And
I
then
think they look on the that direction whether it's a positive and negative only, but yeah, but not in the absolute count actually.
by direction also some are different. Let's say June 2021, there's a minus here and there's no minus there.
What in la model.
Then there are differences.
Yeah. But otherwise yang lain.
It could be maybe they thought this is something small lah.
Yeah.
Small, then you must comment lah. See
Mm-mm.
what is considered as small differences. Non-essential difference lah. But to us, it does not look like it's the same lah or similar,
Mm-hmm.
isn't it?
Yeah, yeah.
I mean, one thing, but perhaps is incomplete reporting. If they should they describe, comment, and discuss, then perhaps you can agree more or disagree more. Okay.
Okay. And then, okay. And then for the discussion part, so I basically for discussion, actually they divide it into the five phase, on the five team lah. On the initial period, reversals, and then impact in the specific age group, and also the scarcity of the published data at the Southeast Asia, and also on the methodology and limitation. So basically I try to summarize it because it's a very lengthy discussion. Maybe I might miss some of the discussion of it. So for the initial period of the early 2020, there is a very minimal change in the overall mortality rates, meaning from the observed and also the predicted mortality, which is almost similar from the training period, which is suggests that there is a local transmission of the COVID-19 is very low during that period, and it might due to strict lockdown and also people are already at home that reduce significantly reduction in the observed death. However, for the reversal in the 2020, we noticed there is a rise from the July to September 2021, which is particularly corresponding to the surge in COVID-19 case and widespread of the Delta variants. And then the impact in the specific age group, mortality among individual under 15 years of age show that there is a decreasing trend, possibly due to a reduced non-COVID-19 pneumonia mortality. And it also reduced human interaction, mask usage, hand hygiene, and physical distancing measure likely contributed to this decrease. And also the RTA mortality, the leading cause among the 15 to 15 also reduced significantly during movement restrictions. It is a common sense, right? And then, unfortunately, in Southeast Asia, there is a very limited published data on the excess mortality in the Southeast Asia, which highlight the needs for improve the statistical surveillance in this region. And the study also emphasized that there is a need for collaboration within our area, Southeast Asia, to make a good system for the surveillance system to monitor the future pandemic and public health threats. And then they mentions that they say that they use a robust aberration detections to analyze a large data set over the 21 months. However, there is a delay in the reporting, so their data set might be there is some data might be not reported, and however the analysis focus on the all cause mortality, so it might not able to mention the contribution specifically of the COVID-19 to cause that mortality. And then conclusion from the author is there is no excess all cause mortality for Malaysia in 2020. And however, there's a significant increase in the transmission that lead to the excess mortality in 2021, especially between July to the September 2021. And they highlight the importance of the monitoring the trends in all-cause mortality in identifying any excess in all-cause mortality, such as in the COVID-19 pandemic. And the all-cause mortality remain a very valuable adjunct to the traditional surveilling mechanism. And then surveillance of the mortality in the future can increase the capacity of the health system to detect any aberrant events for more timely public health intervention. And our current surveillance strategy should incorporate excess mortality surveillance within a resource scarce setting. And it is also essential to keep in mind that the true burdens of collateral mortality is still hidden until now. And then it is must be consistent of mortality must be continued as we continue to deal with the COVID-19 while slowly coming to the grips with its fallout. So, Prof, you want to add on anything from their conclusion?
I still don't believe they have completely reporting or discussed or comprehensively discussed their result. You know,
Okay.
they can keep on saying that the excess mortality is 80%, 90%. What about the more than 100%? What does that mean? You say so high and then you ignore the more than the ceiling kind of proportions, then that actually put a query on the quality of the data, or
Mm,
the robustness of the analytical strategy. You know, they may want to be careful on saying that. Uh, let's say you if you excess mortality due to COVID-19 is 100%, meaning to say all deaths are due to COVID-19, which is not making sense, which is cannot be true, because there are still other deaths due to other causes. So when this is not does not hold, so whichever average excess mortality due to COVID-19 also may not hold. When it does not hold, then we be careful when we conclude of that proportion, excess death proportion, because one does not hold true, that cannot hold true as well, because it all generated from the same modeling.
mm-mm.
So I also find they don't discuss that sufficiently. I
Yes.
hope they can discuss it more sufficiently.
Yeah.
At least you can also suggest perhaps there are different way of analyzing it, or whether you want to you know say something about your analytical strategy, or you could say something about whether the data set was problematic or
Mm-mm.
something. So if anyone come along, let's say you come along and want to do something similar, so you will actually inform by this study that data set perhaps got this problem. So you will be careful or do something about it, or select different kind of period or that kind of thing. But if they don't tell us that, so and keep prejudice and all this, prejudice scientist and prejudice author lah. You always believe the way you do is the best way, so people can't learn after you, see, and people are not informed whether the data sets are good or not for this kind of analysis. uh, so I'm not sure whether we can take away anything from here.
Do you think we can replicate from the statistical analysis? That my concern is I'm not able to replicate
It's not
this.
whether I
Yeah,
cannot,
yeah,
I
yeah.
don't want to, because I
Uh,
can explain the more than 100% proportions of excess debt due to COVID-19. Excess debt could be two things lah. One is underreporting, or people die and then not registered with the country. Ugh, both are very hard to conceive. In this Malaysia, we are not considered as very backward country. We are quite modern, and our reporting are quite modernized as well. I think you may argue they were underreporting.
mm-mm,
Oh, were the death all gone? Pergi mana? Orang, every person that die has to be reported. If they don't report it, then it become a legal issue or what, isn't it? We have to
mm-mm, mm-mm.
carry them out, all the mayat. So you say underreporting, from what? From where? Is that something to do with the statistic were wrong? So it's another way is to say that the quality of the data was not good lah. The one that reported to KKM,
Mm-mm.
the COVID-19 death. So it must be something wrong with that lah. Or it could be something wrong with the predicted mortality lah, isn't it?
Yeah. I
Yeah.
think yeah, I think I really agree on you on there might be some issue on the predicted mortality, especially from I think that the data is might be not enough actually in term of doing the prediction, actually in term of putting the algorithm into the model.
Mm. So that's another part lah. Perhaps we can't uh, comment much because our level of
Yeah.
experience and knowledge it wasn't
Mm.
that. But they being the author, I suppose they have the responsibility to explain so that we can understand to some extent.
So
Okay.
I
I
think
think.
we
Mm,
almost at the end actually. So actually I try to find a good way to appraise, but I think this is the easiest
These are recruits.
yeah, yeah, the recruits lah. For those who did not know that actually Fortune nak mention something tak pasal ni?
No lah, you go and use it and see.
Okay. Basically our recruits is basically divided into the three things. First is relevance, then credibility, and then usefulness. So from the relevant relevance there are three domain lah. First is scientific relevance, then number two is socially relevance, and then whether the team is expert or not. So for me, whether this paper is scientifically relevant, they did, I think, kind of a wide reading, and they're citing a lot of published reading on the mortality, on the all access mortality, and as well as all cause mortality. And so I think the first one, scientifically relevant, is yes. However, for the sociality relevance, it might not be used it's not be useful for the patient per se, but it's more useful on the policymaker. But I do believe that their research team is an expert uh, in term of statistical analysis. Prof, what is your take?
I
Maybe,
totally
huh?
agree. The
Yeah,
societal relevant here may the society here may not always be patients. It could be the policy maker. It could be healthcare providers. So I think the study could actually have this target user and also called society in mind lah. So it's not the patients lah.
yeah.
Yeah.
And then credibility. For the data collection design, it is appropriate for the research questions. However, it's not under our clinical. Yang biasa punya is not experimental. It's not non-experimental. But there is a little bit on the time feature, means that they use a time series here. And then in term of a sample, there is a very large samples. And however, maybe we query on the internal validity and also the precisions. So I might give 2.5 out of 4.
Uh, Agree also with you, but I think there are samples. I think they use all samples. It's
Mm-hmm.
all data. It's kind of
Yeah,
census. They
yeah,
don't do a sampling, so they use the whole thing, the whole data set on the death, on observed death, or that.
yeah. I think just the precision might be just on the subgroup analysis. They did a lot of subgroup analysis. So when they use a subgroup analysis, especially on the they apa tu, on the state punya, when the number is very limited in term of the outcome, so the confidence interval will become bigger, so they're going to issue on in term of positions.
Maybe, but the part on the predicted
Yeah.
estimation and modeling may come
Yeah.
under internal validity lah.
Okay, understand. So you will give 3 out of 4.
At least three lah.
Yeah. Okay. And then usefulness. Maybe this one I call Kak Sawana. What do you think, Kak Sawana?
Why Sawana kena pula?
Saja je, Prof.
Oh, okay. Someone raise a hand.
Oh, ada yang raise eh?
No comment, Dr. Azifah.
Okay. So, I think for the usefulness on the important outcome used and reported, I think from the discussions, um, for me lah, it's very difficult to use actually the outcome actually from this data, but I do believe maybe there's a portions in term of excess mortality, but the way they to present it to make me believe it might be questionable. And then the meaningful estimate, practical numerical value taking into consideration proper statistical test. Yes, I think they did a proper statistical test, but the way they present it, the way they explain it, there are a lot of questions to be answered lah. And then conclusion based on the result. Actually,
Not really, isn't it?
yeah, yeah.
They say something else pula.
Yeah. So I think out of 10, they will get 7, 8 out of 10.
I agree with you.
Yeah.
There's someone who actually wanted to say something, is it? You can just unmute and say anything that you want to say? I couldn't say everyone here because this Google Meet.
Oh, actually, can I just unshare the screen because I cannot see anybody?
Okay, you are done, right?
Yeah, I'm done.
Okay.
Sekejap, eh.
Thank you, Azifa. I think that
Okay.
was very nice presentations as well.
Thank you, Prof.
Oh, no one raised a hand. I thought someone raised a hand. Okay. So we are actually finished appraising that paper. I think one thing that I can say would be the complete reporting lah. Completely discussing and describing how we did something, and then without prejudice, discussing and objectively, how we did something, and that's not easy lah. I suppose we said it here kind of easy. If you did something yourself, right, and then you want to objectively uh, kind of judge yourself, I think that's something quite difficult. Uh, I'm no have don't have formula how to overcome scientists, self prejudice. Uh, the null hypothesis won't do the work lah. I think you say whatever negatively, but when you are already have the result and the mindset is that you always want to see that result, so we tend to just go all the way, believing what we believe, all the way. I don't know how to overcome that actually. And you can sense that, in many papers, whether the authors have that kind of so-called preoccupation of certain result, wanted to see the result, and they tend to see that result, or they say, oh, the result is good. So all the way, the tone of the report is like, it's always on the good side, on the good side, on the good side, on the excess side, like for this paper. So maybe something like you want to step back and then let the numbers speak to you one by one, and perhaps that may help. Okay, so that's all I think from CRU on MGH 20, and we would have again MGH 21 next month. We would try to appraise if you have heard or not heard about implementation trial or hybrid trial. Yeah, recently I learned about that from Prof. Hillary from a unit at Edinburgh, when they actually started to do something more than clinical trial. So it's known as implementation trial. And then also she mentioned about hybrid trial. So I think we want to find a paper. I think the first one is the one that was done by her team. And then we try to look for a good hybrid trial and see how it was done. And then try to appraise whether is there anything good that we can learn or something that we want to be cautious. All right, I should stop here.